This program is brought to you by Trudell Animal Health.
So first we're going to take a look at congenital abnormalities. These are abnormalities that dogs are born with. Starting with pulmonary hypoplasia, which is an incomplete pulmonary development due to the imbalance of bronchial development between lung buds. These have actually more commonly been found where they historically have not been seen in canine patients. We also have congenital lobar emphysema, which is alveolar hyperinflation due to bronchial collapse during expiration, which is caused by the bronchial cartilage being dysplastic or very weak. These patients can develop pulmonary blebs or bulla that can rupture and cause pneumothorax. Primary ciliary dyskinesia is caused by an autosomal recessive gene. It results in ciliary dysfunction that decreases the mucociliary clearance, or one of the defense mechanisms of the respiratory system. Cleft palate or cleft lip is also an autosomal recessive trait that we commonly see with Brittany Spaniels and Great Pyrenees. Most times, if canine patients have a cleft lip, they tend to have a cleft palate. Brachycephalic airway syndrome is probably one of the more common congenital disorders we see. And it really drives the concept of resistance as it's inversely related to the radius. So if you decrease the radius of an airway by 50%, that increases the resistance 16-fold. So think of these patients now that come in with primary congenital anomalies such as stenotic nares, an elongated soft palate, and then has secondary changes due to that negative pressure, resulting in everted tonsils, everted laryngeal saccules, and laryngeal collapse. We also see patients that have abnormal turbinates as well as a hypoplastic trachea, which we believe contribute to the signs. These patients will concurrently have esophagitis, gastritis, hiatal hernias, and pyloric stenosis, which just contribute to the imbalance between respiratory and GI signs. Most of these patients end up needing some form of upper airway surgery to correct the anatomic features that will decrease the resistance needed to breathe. Nasopharyngeal stenosis is a partial to complete narrowing of the nasopharynx by a membrane that's just caudal to the choana and rostral to the caudal aspect of the soft palate. Now let's look at neoplasia of the respiratory tract. Nasal neoplasia in dogs is most commonly reported between the ages of 8 to 10, with a range of 1 to 15 years, so it really can impact them at any stage. There's really no breed predilection, but it's uncommon in brachycephalic breeds to see a primary nasal tumor. Common signs seen with nasal tumors include persistent nasal discharge, sneezing, intermittent epistaxis. Radiographs are often taken, which can demonstrate lytic bone lesions or lysis of the vomer, which strongly support either a neoplastic process or at times a mycotic or a fungal rhinitis if the patient has risk factors for fungus exposure. It's been shown that nasal tumors can occur up to 2.5 times more in dolichocephalic breeds, or breeds with a very elongated muzzle. 80% of these nasal tumors are malignant, with adenocarcinoma being the most common, followed by squamous cell carcinoma. Now looking at the larynx and the trachea, tumors in this area are actually frequently reported in dogs as an ansocytoma, squamous cell carcinoma, mast cell tumor, melanoma, and osteosarcoma. An osteochondral dysplasia is also seen of the trachea, also known as a osteochondroma, which is actually a benign tumor of the trachea, and this is primarily found in dogs that are less than a year old. Most times, surgical excision is actually curative for this type of tumor. Primary lung tumors usually originate from the terminal bronchioles and the alveoli, They occasionally develop as a second coincidental tumor, which can make it hard to differentiate between a primary and a metastatic disease process. 80% of these primary lung tumors are malignant, with adenocarcinoma and alveolar carcinoma being the most common type seen. Primary lung sarcomas and adenomas are rare in the dog. We can also see metastatic spread of primary lung tumors, and they generally spread to the lung itself, tracheobronchial lymph nodes, to bone, and we can even see it spread to the brain. Now looking at inflammatory diseases, we start with the most common, canine bronchitis. This disease process is characterized by a cough that's present for at least 2 months in duration, and it's attributed to inflammation in the airways and a lack of an identified underlying disease that may cause a cough. Most times, canine bronchitis will incorporate a neutrophilic inflammation with mucus, which stimulates the cough. We can see hyperplasia of mucus glands and goblet cells, hypertrophy of our smooth muscle, and fibrosis of the lamina propria, or parenchyma of the lung, which results in fibrosis long term. We can also have obstruction of our small airway and airway collapse. Permanent dilation of the bronchi and destruction of the bronchial walls is a feature commonly seen, which is known as bronchiectasis. Very common in Cocker Spaniels, actually. Middle-aged to older dogs tend to be the population affected. So it's good to know if a big dog presents with a dry cough, I wouldn't jump to think it's bronchitis, as the disease doesn't fit the signalment. That patient would likely go down the route of differentiating infectious diseases such as Bordetella or another systemic ailment. Interestingly, a fair amount of patients with canine bronchitis also have a very pronounced sinus arrhythmia. They can have what's called a cough drop syndrome, where the coughing induces a high vagal tone release and they have syncopal events. Diagnostically, chest radiographs would be taken, which would show marked bronchial thickening, bronchiectasis, and hyperinflation of the lungs. CAT scans provide much more detail and provide you the opportunity to also do airway sampling. In addition, bronchoscopy will give you the opportunity to have cytologies as well as biopsy opportunities for the lower airways. Looking at the cytology from an airway wash in these patients, you shouldn't see eosinophils. Again, they'll have a neutrophilic inflammation. Eosinophils might make you think eosinophilic bronchopneumopathy, which is almost identical. Some patients will undergo what's called an exercise-induced oxygen desaturation, or a 6-minute walk test, where you walk them for 6 minutes and see at what point do they exacerbate and become fatigued, generally showing that the lung just isn't able to have that reserve needed to walk at least 400 meters. Looking at how we manage these patients, that's going to involve anti-inflammatories in the form of oral steroids or inhaled steroids. The opportunity to provide inhaled steroids alleviates any of the systemic effects that the patient may be undergoing with long-term oral steroid use. Beta-2 agonists such as terbutaline may be less effective due to the lack of reversible bronchoconstriction in some of these patients. In addition, opportunistic bacterial infections may occur, and so antibiotics such as doxycycline or azithromycin, which in addition to their antimicrobial properties, have some airway anti-inflammatory properties, may find useful. Fluoroquinolones are also a good antibiotic for these patients, but remember that if they're on theophylline, they need to be dose reduced, just for the standpoint of shared metabolism. We also want to provide some form of a cough suppressive, so utilizing hydrocodone, butorphanol. Similarly, allergic pneumonitis has very common features and shared features to canine bronchitis. It's an acute or chronic allergic reaction of the lungs and small airways. The lungs essentially overreact to the presence of a parasite or other irritant, causing inflammation and a long-term cough. There is often a higher than normal number of white cells called eosinophils in the blood. The underlying cause in these patients is rarely determined. However, home management is usually effective with humidifiers and air purifiers. Eosinophilic bronchopneumopathy, previously known as PIE syndrome, is essentially a group of diseases that are associated with an increased number of eosinophils in the blood and lungs. This group of diseases is one type of allergic pneumonitis, so you see how they all build on each other. Causes of eosinophilic bronchopneumopathy can include anything from parasites to chronic bacterial or fungal infections, viruses, external antigens, and mostly unknown factors. Now we look at structural disease. These are going to include airway collapse diseases as well as bronchiectasis. Laryngeal paralysis, or LARPAR, as it's commonly known, is the result of recurrent laryngeal nerve dysfunction that results in atrophy of one or a pair of the dorsocricoarytenoides muscles, thus impacting our arytenoid cartilage to abduct during inspiration. This is going to result in stridor, which is a very high-pitched wheeze normally found in middle to older age dogs presenting with LARPAR. LARPAR can be considered congenital, can be caused by a trauma, neoplasia. It's even been investigated in myasthenic or hypothyroid dogs. These patients can present in an upper airway crisis and most times need to be intubated. The curative approach would be a surgical approach, for which there are 3 techniques. Most commonly, the arytenoid lateralization procedure is performed where the glottis is widened. There's also vocal fold resections, as well as a combination of the two that could be surgically performed. Laryngeal collapse is the consequence of chronic upper airway obstruction. Similar to what we saw in brachycephalic syndrome with all that negative pressure, it could cause collapse in other areas of the airway as well. Laryngeal collapse as well as tracheal collapse are probably 2 of the common dynamic collapse disorders seen in small dogs. Looking at tracheal collapse, the cervical portion of the trachea will collapse during inspiration, whereas the intrathoracic trachea will collapse during expiration. These patients will commonly present with that classic goose honking cough seen in Yorkies, little Shih Tzus, Maltese. Normally, these patients can be managed medically with weight loss, anxiolytics, cough suppressants. However, at times these patients may fail medical management and need some form of interventional procedures, whether it's a stent or C-rings put in. All right, let's switch gears and apply what we know to our clinical case here. This is Ella. She is a 10-year-old spayed female beagle. Ella is your 3 p.m. appointment this afternoon for coughing. Her owner reports that Ella has had a non-resolving cough that has been on and off for the past 4 to 6 months. The cough is described as dry and non-productive. Some common causes of coughing in dogs, which should be considered, include infectious diseases, lung tumors, pleural effusion, upper airway obstructions or gastroesophageal reflux, interstitial lung disease, and congestive heart failure. Coughing in dogs can often be mistaken with episodes of reverse sneezing and tracheal collapse. Effort should always be made when distinguishing these airway episodes from each other, as they can impact the therapy given in response. YouTube videos are always good auditory and visual references for owners. So you complete a thorough physical examination, and on thoracic auscultation, you note that the lungs sounded abnormal. With cases of lower airway disease, which abnormal lung sounds are often heard? So what did you guys think? Correct, all of the above. Patients with lower airway disease can develop any abnormal lung sounds depending on where in the disease state they are. Evaluation for the presence of a heart murmur is really important, as a cough can be highly associated with cardiac disease. Canine chronic bronchitis is defined as a cough of more than 2 months duration without any underlying cause identified. Airway resistance is created as the airway lumen narrows due to airway thickening and mucus production. Chronic canine bronchitis is like feline asthma, in that resistance is greatest during expiration. However, it differs in that it does not cause bronchospasms. So your clinical suspicion at the moment is for canine chronic bronchitis. Which imaging modality is preferred for airway evaluation? So bronchoscopy is the preferred imaging technique to evaluate the airways and requires moderate sedation or anesthesia. Airway sampling can also be performed at that time, either via a tracheal wash, a blind bronchoalveolar lavage, or via use of a bronchoscope to rule out underlying pneumonia or infectious causes for the cough. After reviewing the diagnostic results, you feel that you have enough evidence to support a clinical diagnosis of chronic canine bronchitis. Treatment is focused on reducing airway inflammation, reducing the cough, and improving the stamina overall. When managing these cases, there are certain aspects of their treatment therapy which is important, including the use of corticosteroids, which can initially start as oral prednisone and can be transitioned to inhalers for long-term use. Bronchodilators can be utilized, although they have limited evidence of efficacy in dogs. Antibiotics, with clinical suspicion of secondary opportunistic bacterial infections, can be used. The best antibiotics for pulmonary penetration include fluoroquinolones, azithromycin, and doxycycline. Cough suppressants are also utilized, and remember, cough suppressant usage must be consistent because they're better at preventing coughing episodes than stopping one. There are also modifications that can be done at home for long-term management of these patients, including elimination of any environmental toxins, such as smoking, incense, air fresheners, avoiding or treating obesity, the use of a harness instead of a collar in these patients, and behavioral modifications. So pets that are very anxious or hyperactive often need anxiolytic use. All right, let's apply what we learned today to a clinical case. This is Tiny, an 8-year-old spayed female Chihuahua who presents to you for coughing. The owner describes the cough as a loud goose honk that will occur intermittently whenever Tiny gets excited. Her episodes seem to be occurring more frequently over the past few days and take longer to resolve. The owner shows you a video captured at home during one of Tiny's episodes. With this presentation, you suspect tracheal collapse. So what would be your next best diagnostic step? While these are all great imaging modalities, your first step would be radiographs. You want to make sure that you obtain radiographs of the cervical and thoracic region to evaluate the entire trachea. As tracheal collapse is a dynamic disease, radiographs should be taken on both inspiration and expiration for the best chances at capturing the collapse. A cervical tracheal collapse will occur during inspiration, and an intrathoracic tracheal collapse will occur during expiration. So you obtain cervical and thoracic radiographs and confirm the presence of a tracheal collapse at the level of the thoracic inlet. Good job. All right, so now that we have our diagnosis, how are we going to treat this patient? Take a look at these. and pick which is the best treatment option to pursue at this time. Oftentimes, the degree of tracheal collapse is minimal and episodes are self-resolving. However, being that the owner has appreciated an increase in the frequency of episodes, starting medical management is recommended, which entails the combination of cough suppressants, anxiolytics, and weight management. Medical management is designed to disrupt the cycle where inflammation triggers coughing, which promotes more inflammation. Oftentimes, the use of short courses of steroids can be instituted for anti-inflammatory properties during more severe episodes, but its use must be strategic to prevent side effects affecting symptoms and quality of life. Inhaled fluticasone through a chamber can be initiated earlier and maintains longer to keep inflammation down and prevent airway irritation long term. Antibiotics should be utilized whenever a secondary bacterial infection is suspected. All right, one more question to wrap up this clinical case. Tracheal stents are considered salvage procedures, with which of the following complications reported? So you should have chosen all of the above, as these are all complications associated with tracheal stents, and medical management should be pursued to its fullest extent. Tracheal stents are by no means curative, and patients will still need to be managed for a chronic cough. So that's the end of non-infectious diseases in dogs. Check us out for Module 5, where we look at non-infectious diseases in cats.